a brief moment. As Leah mentioned, these icons are infused in these programs. It's an ongoing process in our standards work. And I also want to note that we're trying to be most transparent in terms of what is based upon clinical experience or judgment. But you should also know that much of the evidence is very high quality, well-supported Category 1 evidence relying on large-scale human clinical trials and or meta-analysis. So while these icons are important, I think they are also don't tell the whole story of all of the evidence that we have in these programs. So I was just a little bit jealous of Dr. Trindadi's pictures of what lowers her cortisol levels. So I thought I'd put in a few pictures of what lowers mine. This is Mount Baker, Washington, and Northwest Washington. This is one of my favorite creatures to hang out with, who tends to lower my cortisol levels. And I would say that if you can't get along with a lab, you probably have some sort of serious underlying issue. And I did see that Dr. Filomena also highlighted cats. I take that as a personal challenge or affront, but we'll get into this dog and cat issue later, I'm sure, now that I've stirred the pot. So we're switching gears, as I said. What I want to do in two parts today and tomorrow is turn to thyroid assessment and treatment. So my goal here is for you to come away with 5 clinical takeaways, if you will. The first 3 here have to do with understanding assessment, that is recognizing what disrupts the thyroid from working optimally, what are common signs and symptoms, and what's a comprehensive laboratory workup. I'll spend just a modest amount of time on that today because, well, I've already reviewed this in a webinar, as you've heard now a few times, and you received 2 weeks ago. And that webinar goes over these first 3 performance objectives in some detail. As Leah mentioned, this is a 6-week program, really, and we hope to see that that you are getting all of these things, and we're covering these things along a path, if you will. So the last 2 objectives are about what you should do after you've determined the thyroid is out of balance. As Joel has said, it's all about balance. And first, what do you do before you give hormones? That is, what diet and lifestyle factors should you consider? And then what new nutraceutical, what botanical, what medications you should consider, again, before hormone replacement therapy. And then second, if you choose to prescribe thyroid hormone replacement, what choices do you have? What should you prescribe and when? And so we'll cover these objectives both today and tomorrow. Again, referring back to what Joel talked about, there's a bit of a method to our madness, and we want to look at cortisol first because it has so many downstream effects. Of course, we realize it's not only the adrenals that cause thyroid dysfunction. There are a host of other factors, many other ATMs, anticenes, triggers, and mediators that play a large role in thyroid disease and dysfunction. And we really know that thyroid dysfunction is a significant health issue and is only increasing. And there are a number of estimates on how many people have thyroid dysfunction of one kind or another. And those estimates range from anywhere between 12 to 18%, at least in the adult population. So that's 1 in 7 or 1 in 8 adults. A large majority of them have autoimmune thyroiditis. Now, you kind of need to think that also perhaps women more than men by maybe 8 times develop a hypothyroidism. So symptomatically, you shouldn't always think of just the kind of classic weight gain, and I'm going to talk about that in a few moments as well. But so while we're thinking of adrenals, we also are going to be thinking of a number of other things. In order to increase that recognition, we need to understand first what we need to gather. Now, here is the thyroid support decision tree. You've seen the adrenal support decision tree that Philomena went over. So the first part of that tree, as in all of these trees, is that gather section. What should you gather? This decision tree is, of course, again, in this go-to-it model, as you can see here. And again, just to remind you, if you're not familiar with the go-to-it model, you should check out pre-course materials. There's a video that goes step by step through this model. In order to illustrate this gather section, let's start with a case. This case is a patient I saw, Jane. I saw her actually some time ago. She came in with a chief complaint or concerns about some rather common and nonspecific issues, so fatigue and weight gain. While these are nonspecific, these are signs and symptoms that could suggest thyroid dysfunction. In her past medical history, we can see a potential trigger for hypothyroid dysfunction. That's chronic antibiotics, which of course can be a potential trigger or an antecedent of all sorts of autoimmune and non-autoimmune conditions. So those are, again, it's non-specific. She has PMS, she had postpartum depression, she's constipated, 3 more non-specific symptoms that we'll see can often be clues to impaired thyroid function. She has a family history of rheumatoid arthritis, so that would perhaps suggest a genetic susceptibility to autoimmune disease. She has potential nutritional deficiencies or indeficiencies from a standard American diet. Again, another clue to potential problems with the thyroid. She's on a few medications. So she's on oral birth control, which may cause, well, what potential nutritional deficiencies do we know that oral birth control can cause? Well, we know B6, B12, folate for sure, and B6 is also significantly involved in thyroid metabolism. So another clue perhaps. How about physical exam findings? Well, she has dry skin. And that's, again, fairly nonspecific, but certainly can be a clue of thyroid dysfunction. So again, we're going to do a little polling. You know where that widget is now. So pull that out, and we'll start to ask you a few questions. So let's review what antecedents, triggers, and mediators from that story of Jane that you just heard. This is a word cloud, 1 word, or hyphenated 2-word answers. So let's see, antibiotics, of course, diet, of course, standard American diet, even better. Family genetics, so she has autoimmune, that could be a clue of autoimmune thyroiditis. Pregnancy and postpartum depression, I would say, can also be clues. Medications, we talked about medications, so that's good. I like that. Okay, so let's see if we can move ahead here. So let's review. So what ATMs did you see in that story? That's that word cloud. You can see now, of course, here we go. So you have a diagram in your toolkit that this is something I often use with patients. The second objective of this talk is how do you recognize thyroid dysfunction clinically, i.e. in the signs and symptoms of Jane. We also covered that foundationally in this pre-webinar. So again, this is a review. in that webinar, we discussed how to clinically assess by reviewing history and signs and symptoms. Why do I think signs and symptoms are so important? Well, because, and again, as Philomena talked about in endocrinology and specifically looking at adrenal and thyroid and men's and women's hormonal issues, laboratory values are useful, but they're not perfect. Labs can certainly clue you in to avert pathology, but much of this is on a continuum, and they are guideposts. And so signs and symptoms matter a lot because symptomatology is so specific to the individual. So a lot of this kind of assessment is finding patterns and symptoms and then using lab to help as guides and to confirm. So labs may not be definitive, because there's quite a bit of gray in lab. So we're going to go to another poll. And this again is a word cloud. What are the top signs and symptoms for suboptimal thyroid function? And I might add, what are unusual ones that you might think about, but they are more unusual. You can put those down as well. Certainly constipation comes up, fatigue comes up, gain, which I'm imagining is weight gain, hair loss, lethargy, cold intolerance, infertility, the corners of the eyebrows. I see eyebrows, so I'm going to assume corners of the eyebrows, all of those things, thinning, thinning eyebrows, I think. I don't think it's thinning, but I think it's thinning eyebrows. Yeah, all of these are really top signs and symptoms. So as usually happens with my presentations, I'm just spitting, but hopefully I will get out of here. Nope, nope. There we go. So these are the top signs and symptoms of suboptimal thyroid function, as I say. So you're still not seeing that. Okay. These are the top signs and symptoms that I ask about, as you can see there. And again, it's a constellation of these should clue you into, should make you think about thyroid issues in a patient. On physical exam, you might see really various signs. I certainly think of dry skin, diffuse hair loss, edema as the most common I see. And in no way does this diagnose low thyroid function to me, but it does raise my index of suspicion. So we have a woman with fatigue, she has PMS, she has depression, she has constipation, she has some weight gain. Certainly you could think of thyroid, but you could think of iron deficiency as well, which of course may in fact be associated with thyroid dysfunction, because iron is a key nutrient in thyroid metabolism. So what about some of those lesser ones that I suggested? What about keratoderma? Well, keratoderma results from poor conversion of beta carotene to vitamin A. In hypothyroidism, the rate of conversion of carotene to vitamin A is reduced, and therefore hyperkeratonemia, keratinemia, I should say, can occur. It's not often, but you sometimes see that with orange palms. So this is a sign, and we know that also low vitamin A can be a mediator, because vitamin A is, as I'll talk about shortly, is very important to help T3 work at the cellular level. So that's the S, that's the sensitivity in PTSD. What about this? Talking about other signs or other laboratory, incidental laboratory markers. So elevated LDL cholesterol, we often see that. Well, cholesterol makes us think, of course, of the base of the matrix and diet and exercise, as it should. but both total and LDL cholesterol levels are often increased in patients with hypothyroid dysfunction. And in those patients, this is due to decreased levels of T3. So T3 is necessary for LDL receptor activity. With low T3 and decreased LDL receptor activity, you get decreased breakdown of LDL from the bloodstream and thus higher serum LDL levels. This is why people with hypothyroid issues will commonly have an elevated total cholesterol and or an LDL on a lipid panel. So increasing T4 and really T3 or the functionality of T3 will help to decrease total cholesterol along with LDL. So that's the kind of relationship there. It's a kind of 2 for 1. Let's talk a little bit more on LDL cholesterol. So T3 helps activate the LDL receptor, but what are other downstream consequences of low thyroid function? So Joel introduced that steroidogenic pathway, that hormone schematic, and he pointed out that LDL cholesterol is important for the production of these steroidogenic hormones, but you need more than just LDL, which you can have plenty of, but you need T3, which is necessary to combine in the mitochondria in order to produce pregnenolone, which is the building block for progesterone and DHEA, as you of course know. This is the reason that you can have sex steroid hormone issues, and low thyroid function is an upstream cause as it drives hormone metabolism. Therefore, low thyroid function may lead to not only increased serum cholesterol, but also low sex steroid production, and thus, PMS and dysmenorrhea and low testosterone, et cetera. So again, signs and symptoms may be a primary way you diagnose, because sometimes you can't always do a comprehensive lab evaluation. And we need to understand that all these symptoms don't have to be present, as I think an important point, thyroid hormones can have differential effects on different tissues in different individuals. So issues with tissues, as my colleague, Dr. Robert Luby would say, thus one person may have depression and arthralgias because the tissues in the brain and the muscles may be preferentially affected, and thyroid hormone metabolism is not sufficient there. Some other individuals are depressed secondary to thyroid dysfunction. Others are fatigued, but they may not have constipation. And others do have constipation. Well, why is that? That's not exactly clear, but it is clear that tissues can be affected differentially. So Jane had a number of clinical indications for low thyroid function. What's another way to get that information quickly, particularly if your index of suspicion is raised? Well, a questionnaire like this one, which is again in that toolkit. In Jane's timeline, we've plotted some of these suggested signs and symptoms: depression, PPD, PMS, etc. There are so many symptoms that can relate to low thyroid function. Of course, they are obviously non-specific, but I think you can see a pattern can emerge. So why we shouldn't just be looking for the typical overweight, fatigued woman. And while Jane fits that picture here, that is just not always the case, as I'll show in some other case examples. So to finish this review, how do we test? We covered that foundationally in the webinar as well. So again, this will be a brief review. If you look at that decision about that laboratory workup, first, you need to understand the issues around TSH. I talked extensively about TSH controversies in the webinar. And the conclusions that we drew were, first, based upon lots of research, the reference range is too wide. Second, we discussed the issue of subclinical and whether we should rename that suboptimal. And again, a lot of research suggests that subclinical has some significant clinical consequences. And third, we hopefully disabused you of the notion that TSH is adequate for a screen. TSH alone is not adequate as a screen, and should not be the sole diagnostic criteria. We need to dig deeper. Therefore, TSH is not the only thing to test. We need to assess T3, T4, reverse T3, and these ratios, which I also talked about in this in that webinar. So the idea of looking deeper, specifically at T3 and these ratios, is really gaining traction around the world in research and professional societies. So the European Thyroid Association has clearly started to look at this kind of a workup and the consideration of what is happening with T3. Additionally, if you read the clinical practice guidelines for hypothyroidism in adults, co-sponsored by the Association of Clinical Endocrinologists and the American Thyroid Association, they talk about this T3, T4 ratio. And they state that, you know, there are still unresolved issues raised by studies. There are reports that some patients prefer this combination of T4 and T3. So what are these societies saying? Well, I think they're all saying in various ways that we should take into account patient preferences and patient individuality. It hasn't all been worked out. This is an evolving science. I would just like to think that we at IFM are just a little more willing to push the limits of what we should consider evidence-based medicine. That is that triad of research, clinical experience, and patient preferences. This summary of baseline lab testing gives you, I think, a good overview. I also almost invariably test for antibodies as well, because as we showed in research in that webinar, thyroid antibodies can be the only lab value abnormally elevated in a thyroid workup, and that can be a clinical clue that the symptom picture is related to thyroid dysfunction. Here are the optimal ranges that we have determined versus the standard ranges, although the standard reference ranges, of course, may vary by lab. I have the two ratios listed there, and I talked about them extensively in the webinar with references, etc. Again, I find these ratios quite useful. These ratios seem to be useful to assess, as they're not tied to a standard reference range. And the issues I've mentioned with standard reference range, they're really tied to some optimal ranges. These ratios are, of course, associated with research, as I suggested, and again, associated with more optimal functioning. Finally, I want to review some of the additional testing to help us find some of these underlying triggers and mediators. The first thing I'll talk about is, well, I'll say that these laboratory assessments are split up into kind of two categories. First, the critical nutrients, and then other potential triggers from a laboratory perspective. So the first three tests to consider from these nutrient evaluations are looking at three of these 6 critical nutrients that I assess in thyroid function. And the ones that, these first three, the ones that I regularly test for if I can. Iron, I mentioned iron before, it's important, and therefore CBC, of course, but also I almost invariably am trying to get a serum ferritin, which is a more sensitive indicator of iron stores. This is, again, generally part of a standard thyroid workup for me. Vitamin D has critical function in thyroid physiology, all sorts of other things, and I find it's less than optimal often, and therefore I find it important to test if possible, as I don't want to undersupplement, and I do want to make sure that it's being properly absorbed when I do supplement. Finally, iodine, which is a double-edged sword, as I discussed. Too little is can cause problems. Too much can cause problems. Both of them can cause thyroid dysfunction. So I want, again, to make sure they are getting optimal amounts. As I said, there's 3 other nutrients I look at um, uh, um, regularly. I got ahead of myself here. Um, these three that I test for, these are the optimal ranges that I look at. Ferritin above 100, iodine, a first morning iodine fasting urine, 100 to 300, and vitamin D, I think optimally, a lot of literature suggesting it's 50 to 80. And then these three other nutrients, which I think are also critical, but I order less testing because they sometimes can be expensive. They're not necessarily covered. And the levels I generally supplement, I think are quite safe. Now, vitamin A is critical, as I mentioned before, and I may order a serum vitamin A. Zinc is also critical. I sometimes order RBC zinc. Again, I find these reference ranges not a good indication of optimal ranges, so I sometimes will supplement anyway. Selenium is also critical and can be measured by RBC selenium or whole blood glutathione, but function. I almost always supplement at levels that I'll talk about shortly. And then this second category of additional lab digs deeper into other potential triggers and mediators of thyroid dysfunction. Certainly, the first is assessing for food reactions. And we need to remember that we eat 30 to 50 tons of food in our lifetimes. That's maybe half a ton a year of food. That's a huge source of potential antigenic exposure. So specifically, I almost invariably want to rule out celiac disease. That's the first food reaction. And having one autoimmune disease means you have a 15% chance of having another autoimmune disease. Autoimmune thyroiditis seems to be very closely tied to celiac disease. There's a lot higher prevalence of one if you have one of the other. So celiac disease, a panel for celiac disease is important. Then food sensitivities in general is another area I may want to explore, looking at IgG delayed food sensitivities. Third, I may want to look at toxicants and toxic minerals in specific, as we know that toxins, again, in general, can be a trigger and a mediator of thyroid dysfunction. So certainly looking at these minerals of cadmium and mercury and lead and arsenic can be very useful. There are various other toxins, of course. Joel mentioned phthalates. It's just very hard to assess for many of these toxins. They are shadows on the wall, if you will. So we need to think about how toxins affect the thyroid. We know that they do, and do a good screening. There are screening questionnaires that we have, and realize that we're all exposed to toxins. Finally, think about the gut and a stool analysis and or a breath test for SIBO if it's indicated. Looking at the digestive tract is, as we kind of talk about incessantly in functional medicine, is really a fruitful area to explore because of this vast interface that's so foundational to health. So as I reviewed in the webinar, there is now good evidence to suggest that SIBO may be a trigger or a mediator of thyroid dysfunction. So just to keep you on your toes, a question on nutrient supplementation. What is the National Institute of Medicine adult recommendation for the tolerable upper limit of iodine? We have choices of 1,100 micrograms, 900 micrograms, 290 micrograms, 5,000 micrograms, or 5 milligrams. So we're seeing a horse race between 1,100 and 900. That's good. The answer actually is 1,100 is the National Institute of Medicine's upper limit. Going above that, you have to be careful because, as I said, that can cause some thyroid dysfunction on its own. So another question, just kind of getting back to what you do, how many of you are regularly assessing for reverse T3 in your patients? Talked about T3, we'll talk about it more today and tomorrow. And so we see that many of you are, so maybe half of you are and half of you aren't. So hopefully when I've finished talking today and tomorrow, you'll find it useful. Hopefully you'll look at that literature on reverse T3 and find it compelling. I almost invariably try to get a reverse T3. Let's go back to Jane. Her laboratory showed, what did it show? It showed a MCV and MCH at the low end of the normal reference range. Ferritin, what I consider very low end of normal and certainly not optimal, is highly suspicious, particularly the ferritin in the context of her symptoms. So here was the rest of Jane's lab. So just looking at this, so is TSH suspicious? I don't think it's suspicious. We talked about 2 to 2.5 is optimal in that webinar. Free T4, I think that's optimal if you're just looking at that. Free T3, well, it's below the reference range, so it's clearly not optimal. How about total T3? Well, total T3, not optimal, but perhaps within the reference range. Reverse T3, it's not optimal, but perhaps it certainly is within the reference range, and she's antibody negative. Now, what about these ratios? And so how do I then figure out these ratios? So to figure these out, you first have to compare apples to apples, and therefore you need to convert to a common unit. And there are conversion charts that are available online. That's not hard to find. So what I chose in terms of the labs I use, I chose to convert to picomoles per liter, as that's the common measure that I'm going to use or that I use. So in this case, so my lab gives me free T4 in nanograms per deciliter. So you get to get to picomoles per liter, I multiply by this conversion factor, 12.9. So 1.3 in nanograms per deciliter, that's what the lab was, times that factor gets me 16.77 picomoles per liter. And then the same thing with the free T3 by the appropriate conversion factor. You can see 1.56 and gets me to 3.28. So I then take those conversions to figure out the ratios. This is dividing free T3 divided by free T4 and total T3 by reverse T3. Why do I use total T3 instead of free T3? Because the literature is almost invariably using total T3. So when you do that, the T3, T4 ratio is low, and anything below 0.33 is low. It suggests poor conversion. Total T3 and reverse T3 results already were in these common units, so I didn't need to convert those. So that total T3 reverse T ratio is also low. Below 6 is low, which suggests that T4 is converting to reverse T3 more preferentially. These are two separate ratios which often track together, but not always. And we can have one or both of these processes happening individually or simultaneously. So if just a poor conversion of T4 to T3, that's a low T3 to T4 ratio, then you want to do things that promote that conversion. If a low or depressed total T3 reverse T3 ratio, you want to consider what is pushing the conversion to reverse T3. What stressors are we dealing with, and what can you do to change those? So with Jane, clearly I would supplement with selenium and zinc, which are key cofactors in that conversion of T4 to T3 that deiodinase enzyme that needs those two nutrients. And I would look at factors that might be pushing things to reverse T3. Is it toxins? Is it medications? Is it stress? That's that toolkit item I showed you and the literature that I talked about in that webinar. As I said, 1 in 7 or 1 in 8 are hypothyroid. So hyperthyroid disorders are important, and there's some similarities to how to gather and organize as we do in hypothyroid. But for time's sake, we're just dealing with hypothyroid in this presentation. Now what we'll do is spend the rest of today and tomorrow on how to intervene therapeutically. The initiate section of this decision tree, first, diet and nutrients needs for optimal function, for decreasing inflammation, improving that all-important GI barrier function, and the production of T4 and the conversion of T4 to T3, as I have reviewed before and we'll talk a bit more about shortly. So next, we need to also hone in on these other lifestyle issues that can decrease chronic stress and decrease that elevated cortisol that Philomena talked about so eloquently. All of these things, sleep, exercise, meditation, or spiritual path relationships are can fundamentally improve thyroid function. We need to think about toxins, of course, eliminating or decreasing toxins and medications that affect thyroid function. And we know how sensitive this gland is to the environment. As Jeff Bland has said, the thyroid gland is the sentinel organ for detecting environmental toxicity. Finally, here, we want to think about conditions that can influence the functioning of the thyroid. In particular, it's important to look at, as I mentioned, celiac disease, but also autoimmune conditions. Lowering chronic inflammation, which is a key mediator of all sorts of chronic diseases, is of course important. And I would say I can't necessarily always find the underlying cause for thyroid dysfunction, particularly in autoimmune thyroiditis. I often use the analogy that the horse is out of the barn. The immune system is on a feed-forward cycle that's sometimes difficult to break. However, if we can decrease chronic inflammation, improve thyroid function through all these tools we have in the functional medicine toolkit, we can greatly improve the course of a patient with a low-functioning thyroid gland. And we, of course, need to implement these dietary and lifestyle factors that remove or minimize these triggers. And again, to reinforce, we want to look at food reactions, dysbiosis, and overall inflammation. That breach of the gastrointestinal barrier is probably the single biggest source of dysfunction that we know of. This is foundational functional medicine, and how we repair that breach is crucial to improving function. I'll bring you back to this foundational area that we've discussed in various ways in AFMCP, and we created this schematic which draws on many lines of research, which I've hidden in the following slide. So this schematic suggests that all these things, poor dietary choices, stress, infections, all these things are triggers for increased intestinal permeability. That can lead to these increased food reactions, malabsorption, and then malnutrition, and uptake of toxins and lipopolysaccharides, and then the elevated burden, which leads to inflammation, immune activation, and then systemic disease, including thyroid, but not limited to thyroid dysfunction. Therefore, if we are starting foundationally, we want an overall dietary program that lowers potential foods that cause reactions, that decreases inflammation through prebiotics and probiotics and high phytonutrient content, that lowers the the ratio of omega-6 to omega-3 fatty acids that lowers these inflammatory saturated fats. So from a dietary perspective, our first therapeutic option is the elimination diet, which is a program designed to do all of those things and more. There are a number of important attributes here for an individual with thyroid dysfunction, and particularly autoimmune thyroiditis. We know diet plays a role in likely the initiation and certainly the mediation of inflammation. And there are a variety of studies that support this, some supporting specifically looking at autoimmune thyroiditis. There are now some small studies that specifically look at AIT. This was a 2019 study that showed over 10 weeks a protocol that involved a dietary approach similar to the elimination diet, improve quality of life. And then we would often transition to a detox food plan after a comprehensive elimination diet. As I said, and we know toxicity is an important driver of thyroid function. So this food plan builds upon food trigger identification, looks for cleaner sources of food, reduces toxic burden, and continues to target nutrients that support the detox pathway. Well, how about blood sugar and insulin? Does elevated insulin or poor blood sugar control directly or indirectly lead to poor conversion of T4 to T3? Well, the answer is yes, as this research and more shows elevated glucose can be linked to disordered thyroid function, and hyperinsulinemia and insulin resistance lowers the expression of enzymes that help in that T4 to T3 conversion. So if you expect that issue, you want to focus on correcting blood sugar, correcting insulin, and so you want to focus on the cardiometabolic food plan, which does all of those things and more. And this is a particular plan which also has optional caloric targets. Well, we can look at all the dietary interventions in a simple time. There's new citations. They're really an excellent therapeutic dietary tool to personalize for your patients. And